Welcome everyone. My name is Dr. Amber Cann, and today we will be reviewing medications used to treat bipolar disorder. There are a number of treatment guidelines published on treating bipolar disorder. A few are mentioned here, but you may find one that is used in your facility that is preferred over another. It's estimated about 6 million Americans suffer from bipolar disorder and 60 million people worldwide. There's a lifetime prevalence between 2 and 4% in the global population. The most concerning reason that we want to treat early and aggressively is that there is an increased risk for suicide attempts and suicide completion in people who suffer from undertreated bipolar disorder. Generally, we see onset of symptoms in the mid-20s, and we generally see them in males earlier than females. Another reason bipolar disorder is so important to treat is that it is the most costly mental health diagnosis. We spend more money and resources to treat bipolar disorder than any other mental illness. There's a strong familial component in bipolar disorder. About 90% of those diagnosed with bipolar disorder have a relative with a similar mood disorder. Females are more likely to have depressive episodes than males, and they're more often likely to have a concurrent substance abuse diagnosis. Studies indicate that psychosocial stressors may trigger onset in those at risk for bipolar disorder, and they may trigger episodes in those who have a diagnosed condition. The key feature of bipolar disorder is mood cycling between manic and depressive episodes. In fact, this disease used to be called manic-depressive disorder. The manic episodes are characterized by an elevated, expansive, and irritable mood, an increase in goal-directed activities, and can cause a marked impairment of function at work and social settings. In fact, some people do engage in risky behaviors during manic episodes like sexual promiscuity, excessive spending, gambling, or even IV drug use. Hypomanic episodes are characterized by similar criteria as manic episodes, but the mental status change is not severe enough to cause a major dysfunction in work or social activities. It's something that's observable by others, but not disruptive on the whole. And there are no symptoms of psychosis during hypomanic episodes. The other side of bipolar disorder are the depressive episodes. They're characterized by some of the major symptoms that we see in major depressive disorder: extended depressed mood, sleep disturbances, both difficulty falling asleep and also excessive sleeping. Patients may also lose interest in the usual activities that they normally find enjoyable. Patients sometimes say that they also have feelings of guilt, worthlessness, and even suicidal ideation. These depressive episodes can also cause a major impairment in work and social settings, and it is here that we worry a lot about completing an attempted suicide. Here's a graphical representation of what one might experience during a bipolar disorder cycle. You can see the mania is here at the top in this part of the graph, and the depressive episodes are down here at the bottom. For a patient who has not been diagnosed with bipolar disorder, we see maybe this green line. So there could be some good days, and then perhaps a change in job or a death of a loved one causes a depressive episode, but not near to the depths that we would see in someone with bipolar disorder. For someone with unipolar depression, they might follow this blue line. So the blue line may delve deeply into the lower depths that we might see in a bipolar patient. For a bipolar patient, they may have this cycling of depressive moods that are very deep, followed by very high manic episodes up here at the top. And you can see that perhaps they might last a week, maybe 4 days. Sometimes manic episodes can last as long as 3 to 6 months. Every patient is different, and we need to monitor the patient, get a symptom diary before we go into treatment. To treat bipolar disorder, we have several goals of therapy. First and foremost, ensuring the safety of the patient. If the patient is in a severe depressive episode or a severe manic episode, the safety of the patient might be at risk. So we need to stabilize the patient at that point. Then, of course, we need to minimize drug effects and improve a consistent adherence to the medication regimen. Oftentimes, bipolar patients will say that they have difficulty taking their medications because during manic episodes, patients say they want to maintain the high feeling that they're on, and certainly compared to the depressive episodes, it's preferable. During depressive episodes, patients also struggle to take medications regularly because they may even struggle to get out of bed every day. We want to prevent or minimize cycling between manic and depressive episodes and sort of flatten the curve and keep them at a more stable mood. Some of the non-pharmacologic treatment that we have available to us with major depressive disorder is also something we can use with bipolar disorder. Those things include therapy and counseling, of course, a consistent diet, sleep patterns that can normalize. We can also use electroconvulsive therapy or ECT. Some have suggested bright light therapy for depressive episodes, although the data is not conclusive. And then finally, we can use RTMS or repetitive transcranial magnetic stimulation. The hallmark of treating bipolar disorder are the mood stabilizers. We will focus on the 4 I've listed here: lithium, valproic acid or valproate, carbamazepine, and lamotrigine. Lithium is probably the oldest and most studied medication we use for bipolar disorder. Brand names include Lithobid and Escalith. We use it to treat specifically the manic episodes and maintenance of bipolar disorder. The way that it works, it affects reuptake of norepinephrine, serotonin, GABA. It also alters cation transport across the cell membrane, so it has a number of mechanisms of action. At one time, the soft drink 7-Up was called lithiated lemon soda. It actually had lithium in the formula. One of the unique things about lithium is it's not metabolized by the liver or the kidneys. It's actually just filtered by the kidneys for excretion. That means that there are many drug interactions we need to be aware of at the kidney level. For patients who are on lithium, we monitor CBC, thyroid, their weight, and regular metabolic profiles. Because it can cause fetal cardiac abnormalities in the first trimester, we definitely want a baseline pregnancy test before we start treatment and regular pregnancy tests thereafter. The patient should also be counseled on use of a reliable birth control method. Lithium is something that it is similar to a electrolyte in the system, so we need to monitor the EKG, and we can monitor lithium serum levels because it does have a narrow therapeutic index. Lithium has a number of adverse events that are associated with treatment, even at lower doses. Nausea, diarrhea are common, especially at first when starting therapy. Hypothyroidism is something we see in patients who are taking long-term lithium, and that's why we monitor thyroid status. Very rare cases of diabetes insipidus like syndrome have occurred, and sometimes you will see small reductions in the GFR and increased serum calcium. All of these reasons are why we monitor regular metabolic panels and electrolyte levels. I mentioned that lithium does have a narrow therapeutic range, and for that reason, it's very important to monitor serum drug levels. When a patient has a low level of toxicity, a mild level of toxicity, we may see nausea, vomiting, diarrhea, lethargy, and it's hard to suss out whether this is just normal adverse effects of the drug or venturing into toxicity territory. There may be a fine hand tremor when the serum level gets around the 1.5 milliequivalents per liter level. Moderate toxicity exaggerates what we might already see, and that includes also slurred speech, unsteady gait, confusion, and a coarse hand tremor. Moderate toxicity happens between the 1.5 and 2.5 milliequivalents per liter level. And then finally, severe toxicity can lead to seizures, stupor, arrhythmias, and it can be life-threatening. We generally will call a serum level above 2.5 milliequivalents per liter the serious or severe range. One thing to note about lithium toxicity is that it is pretty common, and we cannot administer activated charcoal to reverse the effects of an overdose. In 2016 alone, the American Association of Poison Control Centers said that there were 6,900 cases of lithium intoxication, and a lot of these resulted from unintended overdose from dietary supplements that contained lithium. If a patient on lithium is suspected of venturing into lithium toxicity or is suspected of having a lithium overdose, it's important to assess hydration status and other medications that may exacerbate the condition. Some of the medications that can precipitate lithium toxicity when given concurrently are diuretics, ACE inhibitors, and NSAIDs. With lithium toxicity, we find nausea, vomiting, diarrhea, changes in the EKG, specifically a prolonged QT interval. We may see bradycardia, ataxia, mental status changes, and the tremor in the hands. The most important measure of treatment for lithium toxicity is the ABCs: airway, breathing, circulation. We want to make sure that those things are supported. We usually give a lot of hydration, and if necessary, we can do hemodialysis. A handy mnemonic for remembering which medications cause lithium drug interactions is TALANS, TALANS, and that stands for thiazides, ACE inhibitors, loop diuretics, ARBs, NSAIDs, and sodium. This last one, sodium, isn't necessarily a drug, but it is in the diet, and patients should be counseled that a regular level or a consistent level of sodium in the diet is key to preventing sodium-lithium drug interactions. Let's now move on to the second mood stabilizer, valproic acid. You may also see this referred to as valproate or VPA. Brand names include Depakote, Depakine, and Depakon. VPA increases availability of GABA to brain neurons, and it also enhances the action of GABA at the postsynaptic receptor sites. It comes in a variety of dosage forms: immediate release, extended release, an oral solution, oral sprinkles, and IV. VPA has lots of metabolism through multiple CYP liver enzymes, and so therefore it is definitely something that causes a lot of drug interactions. For patients on VPA, we monitor a CBC, liver function, serum creatinine. Because it can cause fetal neural tube defects, we definitely want a baseline pregnancy test and regular pregnancy tests thereafter. Again, patients should be counseled on using reliable birth control while using valproic acid. VPA is another medication we can monitor serum-free VPA levels and check for toxicity and therapeutic levels. Valproic acid has a boxed warning related to major congenital malformations. These include neural tube defects, decreased IQ scores, craniofacial defects in the fetus, and cardio-neurodevelopmental disorders. It can also cause vascular malformation and limb malformations. So this is definitely a medication that we should never use in a patient who is pregnant or who is considering conceiving. There have been reports of severe and even life-threatening pancreatitis in patients taking VPA. If a patient has a history of pancreatitis or is taking other medications that put them at risk, VPA is probably not the best choice. There is a higher incidence of hepatotoxicity in the first 6 months of use of VPA, so it should never be used in patients who have active liver disease. For patients who go into toxicity because of an overdose, we can administer activated charcoal in those patients. For mild toxicity, we may see sedation, nausea, vomiting, diarrhea, alopecia, and decreased blood ammonia. Those are in cases of sort of longer term, over the time toxicity. And in moderate to severe cases, like in the case of an overdose, we'll see liver damage and encephalopathy related to too high levels of ammonia on the brain. Here again, treatment of VPA toxicity is mainly supportive. We support airway, breathing, and circulation. We can administer activated charcoal in the case of an overdose. We provide fluid resuscitation. And in some cases, naloxone. Naloxone has been shown to reverse CNS depression in patients who have high VPA toxicity. Carbamazepine is our third medication we use to treat bipolar disorder. You may see it abbreviated CBZ. There are a number of brand names of carbamazepine products, and those include Tegretol, Equitro, Carbatrol, and Epitol. We use it again to treat manic episodes and mixed bipolar episodes. It works by blocking voltage-sensitive sodium channels. It stimulates release of antidiuretic hormone and interacts with NMDA receptors. This is another one that has a lot of different mechanisms of action. Carbamazepine is also an anti-epileptic medication, so you may be familiar with it when you study seizure disorder. CBZ has a boxed warning of serious and sometimes fatal epidermal necrolysis and even Stevens-Johnson syndrome. These reactions mainly occur in Caucasian populations, we found, but the risk in some Asian populations is even 10 times higher. We'll talk about that in a moment. Carbamazepine has a number of dosage forms available, from immediate release, extended release, chewables, and oral solutions. Now, about that genetic difference that we see in carbamazepine. Patients of Chinese ancestry specifically have a strong association between the risk of developing SJS and the presence of a particular allele variant, and that allele variant is HLA-B1502. This variant is usually found and almost exclusively found in patients of Asian ancestry. So if you have a patient who is of Asian ancestry, maybe you don't know if they have Chinese ancestry, but they are Asian, you should screen them for the presence of this allele variant, HLA-B1502, prior to initiating CBZ. Patients who test positive should never be put on carbamazepine. Carbamazepine has a number of adverse effects, from dizziness, drowsiness, ataxia, nausea, vomiting, constipation, speech disturbances, blurred vision, nystagmus, alopecia, and photosensitivity. This is a nasty drug. Patients that have hypersensitivity to TCAs, tricyclic antidepressants, who have bone marrow suppression or recent use of an MAOI antidepressant should not take CBZ. So that's another warning against using CBZ. It does have another box warning related to the development of anemia or agranulocytosis. So that is why we always monitor white blood cell count and platelets closely during carbamazepine therapy. We can monitor serum levels of carbamazepine to ensure therapeutic levels and that the patient isn't venturing into toxic levels. We get a CBC at baseline and then again every 3 months, and then we can go to annually if everything is normal. We monitor liver function, electrolytes, serum creatinine and BUN, as well as an EKG. It is critical that we monitor CBC at baseline and on regular intervals, because carbamazepine has a risk of the patient developing anemia and agranulocytosis. So we have to monitor specifically white blood cell count and platelets. The final mood stabilizer we'll talk about is Lamotrigine. Brand names of this drug are Lamictal and Subvenite. This is a drug similar to carbamazepine in its mechanism of action and its warnings. Lamotrigine does have a boxed warning related to serious skin rashes and Stevens-Johnson syndrome. The packaging says that these reactions can occur mainly in young patients under 17 years old, but they have been reported in adults as well. This type of skin reaction with Lamotrigine usually occurs within the first 2 to 8 weeks of treatment, so we need to educate the patient about what to look for. Patients taking Lamotrigine have also reported dizziness, ataxia, GI upset, blurry vision, and this effect called DRESS, or drug rash with eosinophilia and systemic symptoms. There is also a boxed warning on Lamotrigine related to developing anemia or agranulocytosis, similar to Carbamazepine. So with this drug as well, we have to monitor white blood cell count and platelets closely. We'll briefly talk about the antipsychotics that have been used to treat bipolar disorder. They're not first-line therapy, but they can be used as adjuncts or as alternatives. Some antipsychotics are more suited to treating depressive symptoms of bipolar disorder, and some are more suited to acute manic or mixed episodes. Now recall, we should never use valproic acid or carbamazepine in women of childbearing age because of the risks to the fetus. We should also avoid lithium in the first trimester. And with any of these, we need to weigh the risk versus benefit of treatment. Lithium can be found in breast milk, and so if a patient must take lithium during lactation, the patient should be aware of the signs of lithium exposure in infants. Those are lethargy, cyanosis, and hypotonia. Elderly patients are just more susceptible to the adverse effects of medications we use to treat bipolar. We rarely see new onset bipolar disorder in elderly patients, so we're looking more at treating patients who are already diagnosed into their later years. We really have to weigh the risk versus benefit here, especially when patients have a terminal illness. A lot of the antipsychotic and antibipolar medications have many side effects that are exacerbated in elderly patients. It's rare that we would use bipolar medications in young children, perhaps a little more common in adolescents. But it is tricky to diagnose bipolar disorder in adolescents and children because a lot of the symptoms overlap with ADHD and major depressive disorder. Lithium is considered the drug of choice in this population. Antipsychotics can be used, but very cautiously. So, to summarize, bipolar disorder is chronic and debilitating. Patients are at very high risk of suicide attempts and suicide completion. Bipolar patients do have difficulty maintaining adherence to medication regimens, and if undertreated, they have difficulty maintaining social and occupational relationships. It's one of the most costly mental illnesses to treat, and so it's very important to stress to patients and their caregivers the importance of medication adherence. We focus treatment on patient characteristics and manifestation of disease symptoms, matching the drug to the symptoms. And we must consider drug interactions and the cost of therapy when prescribing. There are many drug interactions and adverse events related to bipolar disorder, and we need to be very cautious in monitoring the patient. Thank you for joining me for this review of the medications we use to treat bipolar disorder. I am Dr. Amber Cann, and you can find more videos and information at ambercann.com.